This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Welcome, and thank you for joining us. Renal System, Part 3.
Welcome to the NCLEX lecture series. Today we are going to discuss the renal system. This is Part 3 of our three-part series. End-stage renal disease is irreversible damage to the nephrons and glomeruli. It is caused by chronic renal failure, diabetic nephropathy, glomerulonephritis, polycystic kidney disease, or even hypertensive nephrosclerosis. The glomerular filtration rate is less than 90 mL per minute. Remember, the normal GFR is greater than 135 mL per minute. In the early stages, the patient may have an excess amount of urine, polyuria, and renal insufficiency. While in the late stages, we may see oliguria, hematuria, proteinuria, and lots of edema because the client is holding on to all that fluid. What do you think is going to happen to the blood pressure? Yes, it's going to go up. So class, what other symptoms do we see? Well, we see muscle wasting, secondary to negative nitrogen balance. Uremic fetor. What is that? Ammonia taste in the mouth. What do you think? Will the creatinine, phosphorus, and potassium levels go up or down? Up. That's right. Why? Because the kidneys are not working. When the kidney is not working, those numbers will go up. If the potassium and phosphorus levels are high, what do you think is going to happen to the sodium and the calcium? Right, they're going to go down. Why? Because potassium has an inverse relationship with sodium, and phosphorus has an inverse relationship with calcium. Very good. Clients who have chronic kidney disease will also be given medications like diuretics, antihypertensive medication. Remember, as kidney function decreases, medication doses need adjustment. So tell me, what is the renal diet made of? Now class, I don't want you memorizing this stuff because it is easy. What about protein in the diet? Should we increase or decrease it? Decrease it. Why? Because with renal failure, waste products of protein metabolism are retained, so we need to reduce the protein in the diet. What about sodium in the diet? Increase or decrease? Decrease. Why? Because water follows sodium. We already know this patient is retaining a ton of fluid in chronic kidney disease. So if we increase sodium, they are going to retain even more fluid. Not good. So yes, decrease sodium in the diet. What about potassium in the diet? Increase or decrease? Decrease it. Decrease potassium. Why? Because the patient is in anuria. Are they excreting potassium? No. And we know potassium causes some really bad cardiac dysrhythmias. Can my patient have a myocardial infarction? Yes. So decrease potassium in the diet, as this client cannot excrete it. What about phosphorus in the diet? Should we increase it or decrease it? Decrease it. Why? Because phosphorus is being retained. Phosphate binding agents are used to increase fecal excretion of phosphate. For a client who is in chronic renal failure, without renal dialysis, they will die. Dialysis is important to maintain life. We have different types of dialysis. Hemofiltration, a good example is continuous arteriovenous hemofiltration, peritoneal dialysis, and hemodialysis. Hemofiltration is a renal replacement therapy that is prescribed for patients with kidney failure who are critically ill and do not tolerate the rapid shifts in fluids and electrolytes that are associated with hemodialysis. Continuous arteriovenous hemofiltration is an example where the renal replacement therapy is continuous. In peritoneal dialysis, dextrose is used to pull wastes and fluids out of the peritoneum and into the peritoneal cavity. After a set amount of time, dwell time, the dialysate, waste products, and extra fluids are drained out of the peritoneal cavity through the catheter. You must monitor indwell and outflow times closely. Remember, with peritoneal dialysis, the dialysate has tons of glucose. Now, there are two types of peritoneal dialysis: continuous ambulatory peritoneal dialysis, or CAPT, and automated peritoneal dialysis. Let's discuss continuous ambulatory peritoneal dialysis. I have a very good friend who is on CAPD, and he absolutely loves it. Why? Because it's a continuous process and closely resembles renal function. It does not require a machine, and he is more independent. With CAPD, what we have is about 1.5 to 2 liters of dialysate, which is instilled into the abdomen 4 times a day. There is also an overnight dwell time of about 8 hours. Remember, the physician will prescribe the dwell time. After the dwell time, the bag is placed lower than the insertion site and the fluid drains out by gravity. Guess what is done to prevent infection after all the fluid is drained? Yes, we change the bag. We begin the process all over again and instill new dialysate into the abdomen. We usually warm the dialysate before instilling. Remember to clamp the catheter between exchanges. With CAPD, the client performs self-dialysis 24 hours a day, 7 days a week. However, with automated peritoneal dialysis, as the name implies, the exchanges are automated, and a peritoneal cycling machine is required. It can be done on a nightly basis, performed 8 to 12 hours each night on a continuous cycling basis, which consists of 4 cycles, 3 cycles at night, 1 in the morning, or intermittent basis, performed for 10 to 12 hours, 3 or 4 times a week. What is your number one concern with peritoneal dialysis? Yes, infection. After all the fluid is drained, we will observe the fluid. What are we looking for? Clear or cloudy? Clear, yes. We must be able to see through the drainage. What does cloudy mean? It means there's probably an infection. Remember, cloudy outflow is an early sign of peritonitis. Watch out for signs and symptoms of peritonitis. Tell me, what are other signs and symptoms of infection? Fever, rebound abdominal tenderness, cloudy outflow, and nausea and vomiting. We are now going to discuss hemodialysis in a bit more detail because you will come across a lot of patients on hemodialysis. It is usually done 3 times a week and takes between 3 to 8 hours a day. It is life-changing. For hemodialysis to occur, an access like an AV fistula is usually created. Remember what I said earlier. For a client who is in chronic renal failure, hemodialysis is important to maintain life. A client who has chronic renal failure is in anuria, a urine output of 0 to 100 mils in 24 hours, or oliguria, a urine output of 100 to 400 mils in a 24-hour period. I remember caring for a client who had chronic kidney disease. I gave him a lot of meds, and guess what he did? He took them and swallowed them, each one without drinking any water. Yes, they are in fluid volume excess, and this is why they are on a low-sodium diet and need to be on dialysis. Chronic renal failure causes an accumulation of waste products and byproducts of protein metabolism, such as urea, creatinine, and uric acid. This is why we give these clients a low-protein diet. Hemodialysis helps clean the blood of accumulated waste products. It involves the diffusion of dissolved particles from one fluid compartment into another across a semi-permeable membrane. The client's blood flows through one fluid compartment of the dialysis filter, and the dialysate is in another fluid compartment. The functions of hemodialysis means that it cleanses the blood of accumulated waste products. It removes the byproducts of protein metabolism, such as urea, creatinine, and uric acid from the blood. It removes excess body fluids. It maintains or restores the buffer system of the body, and it corrects electrolyte levels in the body. Nursing interventions would include monitoring laboratory values before, during, and after dialysis, assessing the client for fluid overload before dialysis and fluid volume deficit following dialysis. Weigh the client before and after dialysis to determine fluid loss. Assess the patency of the blood access device before, during, and after dialysis. Monitor for bleeding. Heparin is added to the dialysis bath to prevent clots from forming in the dialyzer or the blood tubing. Withhold all antihypertensives and other medications that can affect the blood pressure or result in hypotension until after the hemodialysis treatment. Also withhold medications that could be removed by dialysis, such as water-soluble vitamins, certain antibiotics, and digoxin. Examples of access devices for hemodialysis include an internal or external AV fistula, internal or external graft, a subclavian catheter, or a femoral catheter. Let's discuss the one you see almost all of the time, the internal arteriovenous fistula. It takes about 4 to 6 weeks for the AV fistula to mature. During this time, the fistula cannot be used. Maturity is when the flow of arterial blood into the venous system causes the vein to become engorged, is important, so the engorged vein can be punctured using a large bore needle during dialysis. The large bore needle allows blood to return quickly for effective dialysis. Another access device you may see is an internal arteriovenous graft. This is another permanent access device which usually matures and is ready to use 2 weeks after insertion. The subclavian catheter and femoral catheter are used short-term, up to 6 weeks, or for temporary dialysis. Remember, with a femoral vein catheter, we do not want the client leaning forward or setting up more than 45 degrees. Why? Because we do not want the catheter to kink or occlude. I will say it again. Clients with femoral catheters cannot set up more than 45 degrees, neither can they lean forward, or the catheter may kink or become occluded. While an internal arteriovenous fistula is a permanent access device, it is created by anastomosis of a large artery and a large vein. Hemodialysis is done about 3 times each week, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. With an AV fistula, listen for a bruit and feel for a thrill. On the side with a fistula, no blood pressure, no IV, no nothing. Remember, on the side with the fistula, no blood pressure, no IV, no nothing. Which medications would probably be held for a patient going for dialysis? Well, all blood pressure medications, water-soluble vitamins, vitamins B and C, and digoxin or lanoxin. Let's discuss the complications of dialysis. One day I went into an online chat room for people who are currently on dialysis. I know it is life-changing, but I really wanted to hear from my clients. What do they really go through before, during, and after dialysis? Here's what I learned. I learned that many of these people who are on dialysis were scared. They were frightened. Some describe dialysis as going to death row 3 times a week. One complication during dialysis, and this might be their last day on planet Earth. Is that not scary? Is that not sad? Let's discuss some of the complications of dialysis. Air embolus. This is where air enters into the circulatory system, causing cardiac complications. The signs and symptoms of air embolus are dyspnea, chest pain, hypotension, cyanosis, anxiety. The interventions will stop hemodialysis. Turn the client to the left Trendelenburg position. Notify a physician. Monitor the oxygen levels, vital signs, and pulse ox. Why must we turn the client on their left side and put them in the Trendelenburg position? Because we do not want the air to travel to the lungs. So we trap it. We trap it on the right side of the heart by putting the client in this position. This is a scary time for the patient, so support is very, very important. Next, we need to discuss disequilibrium syndrome. Changes in level of consciousness during or after hemodialysis can signal dialysis disequilibrium syndrome, a life-threatening situation that requires early recognition and treatment with anticonvulsants. Because of this rapid shift, fluid is pulled into the brain, causing cerebral edema. We normally see this in new clients during the initial onset of hemodialysis. Signs and symptoms will be nausea and vomiting, a headache, hypertension, restlessness, muscle cramps, and confusion. Interventions would include stopping hemodialysis, notifying a physician, put them in a quiet environment, and give them medications, IV, hypertonic saline solution, and mannitol. Remember, you are more than a conqueror, and you will be successful. Join me as we review core content in the next unit.